Alrighty, it is 5 p.m. Eastern time, so I guess we'll just go ahead and get started. Welcome everybody to the final speaker session for day one of the National Pre-Health Conference. I'm so excited to have you all here. I hope you've been enjoying the conference so far, and I would love to introduce our session for today, or for right now, why you should consider a physician assistant, presented by the wonderful Shelly Garland. Shelly Garland is a physician assistant who has significant experience working in both emergency medicine and the urgent care fields. She currently works in the greater Phoenix area in the U.S. state of Arizona, serving as a rural emergency medicine physician assistant through the Inova Emergency Medical Associates. She also serves as an urban emergency physician assistant through Envision Healthcare. So she'll discuss her path towards becoming a physician assistant, why she decided to pursue the career, and her role in both urban and rural emergency medicine. Please welcome Ms. Shelly Garland.
Hi guys. So like Avi said, I'm going to be kind of talking about a different range of things. So we'll be talking about both why I became a PA, what is a PA. I think I'm one of the only PA speakers. So we're going to kind of cover scope. What is a PA? What's the difference between MD and PA? And then also what my job specifically in the emergency room looks like and what I get to do as a PA in the ER. So we're going to start with a quick poll of kind of just where you guys are all at as far as if you're decided as being pre-MD, pre-PA, if you're other or undecided, just so I can kind of get a scope of where you guys are at. Okay, cool. So I think most of you are pre-med school with a handful of undecided, a couple PAs, which is exciting. I think slowly at work, we've convinced some of the scribes to maybe switch between what they thought they originally wanted to do and what they're going to be doing now. So maybe after this presentation, you guys will have questions and stuff. Yeah, as Sarah said, she's undecided now. All right, perfect. And then Avi's going to switch over to my presentation. Let me close out that poll. So like I said, we'll be talking just kind of about my journey and then what I do in the emergency room. So we'll start a little bit, Avi, you can go to the next slide, just on my background. So I grew up in Arizona. I was raised in Tucson, and then I moved up to Phoenix after undergraduate. I always knew I wanted to do something in medicine, but I wasn't really sure what. So I did my undergrad in biomedical engineering. I did that so that when I graduated undergrad, I would have a clinical skill I could use if I didn't end up going into like a finishing degree. So I did that at university. In undergrad, I did both clinical research in the emergency room. I screened patients for clinical trials. And I also did research in a lab where I was working, cutting up eyeballs and basically scanning them with lasers, studying glaucoma. So that was like my engineering background. I actually didn't decide to go PA until I was in my senior year. I had applied, gotten into grad school for biomedical engineering, and part of the engineering program, they had you shadow both doctors and PAs and other medical roles. And I ended up shadowing a PA and realized like, I love that role. I had never realized that that was even an option. So I canceled both of my admissions to grad school and took a year off and scribed in an ER to get some clinical experience. That is one thing as a PA program they really look for, is that you've had some sort of direct experience with patients, not necessarily touch hours. You don't have to have like a nursing or MA background, but they want to see that you've worked some sort of part of the medical field and that you really understand, one, what a PA is and that you're going to pick PA, and two, you have some sort of base medical background because the schooling is much faster. And so you're going to want to have some sort of baseline understanding of medicine before you go into it. Whereas med school, it's a much longer process and you can really kind of catch your feet once you're in med school. So then I applied. I was really lucky. PA school is very difficult to get into. Most people apply more than once. I lucked out and got directly into Midwestern on my first round. So that's where I went to my undergrad. There you do, it's a just over a 2-year program. You do the first year is didactic and doing all your classes, and then you have a year and a half of clinicals where you're rotating in surgery, emergency medicine, family medicine, all the same kind of rotations you would do in med school. And you do full-time hours working with the doc. Each rotation is about 6 weeks, and you do that for about a year and a half with some electives. So I did like orthopedic surgery and urgent care were my 2 electives. After school, I graduated, and at that urgent care rotation, I got hired. So my first job was in the urgent care. I did that for about a year. And since then, I've been in the emergency room. I worked 2 jobs, both down on the Gila River Indian Reservation in Phoenix and in some of the metro Phoenix area emergency rooms. So I actually work at 5 different hospitals currently. Okay, Abby. So a little bit about what a PA is, especially if so many of you are kind of decided on the doctor route. A lot of people don't even realize what a PA is or what they do. The full name is physician assistant. I keep referencing as PA because the PA world is trying to change it to physician associate. So you may hear both of those terms. They're interchangeable. At this point, it's still legally physician assistant. But basically we work side by side with doctors as part of a collaborative team. In the emergency room, I see patients by myself independently. And then sometimes we'll run that by or work with my doctor if something is more complex. But in Arizona, I can see patients independently, prescribe independently, diagnose and treat. At the urgent care, I was the only provider there. Depending on the state, there's not necessarily a doctor in-house. But that is one of the things about PAs is that from state to state, the regulations and scope of practice will change. So if you're thinking about PA, it's something you want to look up about the state you're going to be in. So PA programs are usually about 3 years long, 2.5 to 3 years. It's your master's degree. Unlike NP school, you graduate with over 2,000 hours of clinical rotations. NP school tends to be significantly less than that. And then once you graduate, you have to pass a certifying exam. That's a national board exam. Then you recertify every 10 years, and you have to keep up with your continuing medical education. As you'll see on the right, most PAs work outpatient with about the other 50% in the hospital or urgent care. A lot of PAs are in surgical subspecialties. You can be in primary care, emergency medicine. Some of my friends from PA school are doing like very specific fields like craniofacial reconstructive surgery, where they're the first assist with a doc on a team. So the cool thing about being a PA is that you can really make it what you want, and you can really design the job that you want, which is really cool. Okay, Abby, you can go to the next one. So a little bit more about being a PA. The scope of practice does vary from state to state, like I mentioned, but generally you are able to see patients, diagnose them, prescribe them medication, prescribe narcotic medication, and do procedures. In every state, you can also first assist in surgery. You cannot be like the surgeon, but you're first assisting on cases, and often will be kind of like that primary partner on a surgical team. One of the cool things about being a PA that I think a lot of people, I've heard feedback from both doctors and PAs, they didn't necessarily realize before they went into med school that PAs can switch practices very easily. So that's why I picked PA. I knew when I was younger, early in my career, I wanted to do something hardcore like emergency medicine or surgery. But I anticipate that years later, as I have a family and want more work-life balance, I may want to do, primary care or urgent care, something that has more regular hours. And I can switch specialties. I can go into dermatology or surgery whenever I want without having to do a new residency, where a lot of my ER docs that are kind of done being emergency medicine doctors but not ready to retire feel somewhat stuck. They can take on other roles, but that's something to keep in mind, is that once you pick that specialty in residency, you don't have that same lateral movement. And then if you're ever considering moving out of the US, PA is probably not for you. There are some countries where you can practice internationally, and that's growing somewhat, but in general, it's very hard to practice as a PA outside of the US. So we talked about this a little bit, but these are kind of the differences between the two PA MD, and then I just included a bunch of other options that some people might want to consider. So the MD role is obviously the most independent role. You can practice independently. You are like always making decisions. You may go to your coworkers for second opinions, but in generally, like you're the final opinion. I've heard that there's potentially more administrative work. I think this is kind of dependent on your role as a doctor. If you own your own practice, of course, you're going to have more admin work, but that's not necessarily true. Obviously, they have extensive training hours. So you go to med school, residency. A lot of residents have fellows after that, and you don't end up coming out of residency or fellowship until, you know, your early to late 30s. So during that time, you're making very low money and working very long hours. But once you're graduated, you're making significantly more money than a PA, and potentially working less or more. It kind of varies by specialty. Whereas a PA, you're always going to be collaborating with an MD. That doesn't mean you're going to have a doctor on site with you necessarily, but in the state of Arizona, you can't independent practice. In Arizona, NPs can open their own practice, but PAs can't. So that's something to keep in mind if you really want to own a private practice. You could own it, but you would still have to have a collaborating physician that's signing your charts. As I said, the lateral movement is probably one of the biggest pluses about being PA. It really gives you a lot of options to change your career over several years, and you can still really specialize in things if you want. It is lower income, but you're making a lot of money sooner. So I graduated PA school 5 years ago. So I've been making money since my mid-20s. I've been able to like buy a house and do things that like residents wouldn't necessarily be able to do while in their 20s. So you kind of have to weigh like the loans and the time with the income if that's something that's important to you. Some of the deal breakers that I think people should think about when they're deciding between PA and MD is how important is it to them to be independent. If you have a big ego and, you know, taking someone else's opinion, like the doctor's over yours, and you're not always going to agree, if you can't do that, you probably shouldn't be a PA. You know, if you really butt heads with other people and you don't want to be on a team, PA is definitely not for you. Personally, I love the team practice we have at my emergency room. Both the MDs and the PAs and NPs are always running stuff by each other as a team. And I really love that. So that's something to keep in mind. And then we kind of talked about these other things, but if you really specifically want to be a surgeon in a specific field versus a first assist, or a really unique private practice is important to you, then definitely I think the MD-DO route is probably better. The one plus side for PA as well is that early career work-life balance. I think once doctors hit their 40s and 50s, they can definitely reclaim that work-life balance, but you are making a lot of sacrifices in your 20s and 30s, which is definitely something to consider. All right, we can go to the next one. So this slide is more of a shout out to some of my providers I've been working with recently. I think there's a lot of this in the news, and you see this a lot more about kind of the dark side of medicine. I don't think it's something people talk about before they go into med school. I think a lot of people think it's like a great career. Stereotypically, a lot of families will pressure you to go into it because then you're a doctor or whatever, but it is a tough field to work in. And I think it's something to consider. I think most of the providers that are burnt out are probably because they didn't enjoy medicine in the first place. They went into medicine because their family wanted them to, or they thought they'd make good money, but they were never passionate about medicine as a career. And those people come out of residency really, really burnt out and just done, but they're kind of stuck because they have, you know, sometimes $500,000 in loans. Luckily, as a PA, that loan burden is a lot less, and we're more flexible in our ability to move. So I think in general, the PAs are less burnt out. But you know, you're going to be working weird weekend hours, nights. You're going to be working really long hours during both rotations as a PA or as a resident. And more we're seeing corporations come into medicine and really run medicine as a business. So I think it's something to consider. It's not all like butterflies and saving lives. There is like a really hard part about practicing medicine. So I think it's important to choose it because you're passionate about medicine. For me, it was always medicine or nothing else. So I think that's something to keep in mind. Okay, so now moving on to the role in the ER. So as I said, I work in about 5 different ERs. I work primarily down on the Gila River Reservation, which is a small emergency room. And then I work part-time in several of the Banner facilities here, which are up to like 70 bed level 1 trauma centers. So I've kind of seen the whole scope, which is cool. In the ER, I work independently. I pick up patients, work them up, diagnose them, admit, discharge. I consult the specialists. When cases are too complex or there's something weird going on, or I just have questions, my doctor is always available in the emergency room for questions. Looking at ESIs, so that's how you rate a patient. So a level 1 ESI is a very sick patient. They're basically coding, arresting, not breathing. An ESI of 5 is someone that's there to get their TB test checked. It's like not a real complaint. An ESI of like 4 would be like rashes, lacerations, cuts, and then like a 3 would be like your belly pain. So it goes up in acuity. So when you think about working in the emergency department as a PA, the PAs work from the bottom up. So they're going to pick up the patients that are least acute and move upwards, while the doctor is going to move downwards. And at some point there may be too many of those level 1, level 2 patients, and both of us are going to be working on those sick people. But especially in the very busy urban ERs, the PAs help pick up kind of the like more silly ER complaints and get them processed through quickly so that the flow can continue in the department. So for me, I really like that because it means my day is overall probably less stressful. Less of my patients are trying to die on me. I still get to see really high acuity, but I also get to do some easy, quick, help a patient out and get them out of the department. In my ER, it's very collaborative with the doctors. They don't sign my charts on the reservation. So if I need them to collaborate, they can, but I don't have to give them a report on every single patient I see. In the urban ER, I only give report to like new doctors while they're getting comfortable with me. And I'll say like, yeah, give me a rundown of the 10 charts you're going to send me, just so that they know what they're getting in their inbox. But generally I work kind of in my own silo. And when I have questions, I pop over to the doctors. So some of the cool procedures I get to do, there's kind of more common ones and more rare ones. So we're going to kind of go by them slide by slide. I have cool, gory pictures for everyone. So, Avi, you can go to the next one. So one of the most common procedures that we'll do in the ER is lac repairs, especially because this would be like a lower acuity patient in general. The PA is almost always going to be the one that's doing the suture repairs in the emergency department if there's a PA on site. So I do all sorts of different laceration repairs. You're suturing all sorts of complex wounds. Occasionally I'll have to call a specialist, but in general, this is the PA's job, which is really cool. You get to fix up all sorts of interesting things. So we have all different types of sutures there. Incision and drainage is a very big procedure I do, especially with my diabetic patients. We get a lot of abscesses, a lot of infected skin cysts. So here you're seeing an incision and drainage. You're gonna basically play Dr. Pimple Popper, numb it up, drain it, and get people moving along. So we do these probably at least once a shift, not always, but it seems like they always come in clusters. So this is a very common procedure for a PA to do. Fracture reduction is another thing that I can do in my scope. Depending on your privileges at a hospital, some of the more complex fractures will get reduced by the MD, or if orthopedics is on in-house, they might come down and reduce a fracture. But generally a PA is fully within their scope to do fracture reductions and splinting. We'll do conscious sedation with drugs and put the patient under, and then reduce broken wrists or reduce shoulder like dislocations. So that's a fun procedure to get to be able to do. And when you first get comfortable doing those, you're trained with the doc side by side. But now that I've been doing more of them, most of the doctors will let me reduce bones by myself. This is also a common procedure. So here we're watching a lumbar puncture. This is on like a dummy, so you can see the skin looks really weird. But this is to check for like meningitis or other problems with the spinal cord and brain. You're checking and taking out fluid from the spinal cavity to check for infection or blood or other things. Here they're checking the pressure in the spinal cord to make sure it's not too high before they remove the fluid. All right, Avi, you can go next. We won't watch the whole thing. It's not that exciting. And then some of the more rare procedures. So there's a whole list. Now, commonly these will be done by the doctor. So you're talking like chest tube and intubation. We have pictures for those too, so you can go through, Robbie. So chest tubes, I've done maybe a handful of these. So usually the doctor is doing these, but occasionally one of the cool things about being in the rural hospital is that it's one doctor and me. So when something interesting comes in, if we're not that busy, they're like, hey, let's go do a chest tube. Let's have you do the chest tube today. So it's a really cool learning experience. So I have done like 2 chest tubes out in the rural site. And this was in cases of like traumatic pneumothorax where someone's lung has collapsed and you have to open it back up. And then intubation is another one. Obviously, during COVID, a lot of our patients were getting intubated, unfortunately. So typically, if it's just one sick patient in the department, the doctor is going to be doing the intubation. But particularly when there's multiple sick patients, or if it was originally my patient, the doctor may have me do the intubation with them at bedside to be available to assist. Or I might be assisting them during a more complex intubation, which was like the case we had a couple of days ago in the department. Paracentesis is really common procedure. I don't do this very often because at my site, we don't have the supplies, but a lot of PAs, especially working in GI or in the ER, will do this. So if you have a patient with cirrhosis, they're in liver failure, their belly is filling up with that big pile of fluid, it needs to be drained for both either infection or just to release some of the pressure. So they'll basically insert a needle, drain some of that fluid off, and collect it. So it's a pretty low acuity procedure, lower risk, but it definitely has some risk associated with it. So PAs do this with like proper training. And the only other ones that were listed on the rare side that we didn't really talk about was conscious sedation. So I do that somewhat, but usually the doc is at bedside for that. So giving drugs like ketamine or propofol to put the patient asleep for a procedure, with or without airway support. Cardioversion is when you're shocking a patient out of an abnormal heart rhythm, because either the drugs aren't working or they're too unstable. PAs definitely do cardioversions, but typically if a patient is that unstable, hopefully you have the MD or DO around, or at least aware of what's going on. And the only other one on the left that we didn't talk about is splinting. We do a lot of splinting of the fractures that we reduce, and either the techs will do that or will assist. We're speeding through. So we're talking about urban versus rural medicine. It's kind of cool because I've gotten to see both in the last several years. I've been doing both. So we'll kind of talk about the pros and cons of each. We'll start with urban. So in the urban setting, I work in the emergency department that's central in Phoenix, in downtown Phoenix. So it's a very urban, high homeless rate, it's a mixed bag of what's coming into the department. So you have very high volume. You know, we see over 200 plus patients a day in the department. So you're going to have a lot more doctors on per shift. You know, in my busiest ER, we have probably 5 to 6 doctors at any given time and 2 or 3 PAs all spread out throughout the department. So that means when you have that many docs on, the PAs are really going to be utilized to pick up that lower volume, a lower acuity, so the doctors can focus on the really sick patients. So at one of my facilities, they run essentially like a fast track, where they put those lower acuity ESIs I was talking about earlier. So those 4s and those 5s, I'll see a lot of lac repairs, simple belly pains, you know, maybe a UTI or STI, weird rashes will come through the fast track department. And so you're generally getting lower acuity. Now you're still working up some of the sicker patients, but those are generally going to get picked up by the doctors first. You're going to do a lot higher volume in the urban setting because of the fact that you're doing lower acuity. So on any given shift, you may see more than 2 patients an hour, which is pretty high. But again, they'll be potentially lower acuity. The cool thing about being in an urban site, especially like at a level 1 trauma center, is that you've got all the specialists. So at the university I work at, we've got residents for general surgery, we have OBGYN, we have facial reconstructive surgery who can come down and assist. So if you have a complex laceration or a complex fracture, the specialists are in-house, will come see your patient, will come take care of the problem. So you end up making a lot of phone calls, but you're not necessarily the one handling the problems as much, which is cool, but also means you're not doing as much like hands-on procedures if that's something that's important to you. It is interesting because at the university sites, because they have the residents, you end up doing a lot of weird diseases get sent there. So the more rural sites will send their rare problems to the university to get handled. And you're the person doing that intake in the emergency room and kind of helping coordinate the specialists coming in. So at the urban site, I would say you do a lot more coordination and phone calls and, just handling little problems. Whereas the rural site, there's no one to call. So it's just you doing the work. So rural site, I would say it's much more team-based. At my facility, it's a 15-bed emergency room. We have one doctor on at all times and 2 APPs. So we have like a PA or an NP on. And that's it. We have several nurses and scribes, but there's no other doctors on site. So it's very team-based. Everyone, if there's an emergency, everyone is handling it as a team while someone else keeps the flow in the department. So that means that the PAs are really well utilized. We can see all acuities. We can run codes if we need to, because sometimes if there's 2 sick patients, there's only one doctor. You have to be able to jump in and really help. So that's cool. It's a little bit higher stress when things do get scary because there's no backup. But it means that you really get to do a lot and help a lot as a PA, which is awesome. You do also have more patient education. So at my site, there's very little access to other care. They're out in the middle of essentially nowhere. This is like the only facility there is like outpatient connected to the emergency room, but you're going to do a lot more patient education, primary care type education in the emergency room because they're not getting that same access to care that they have at the urban sites. Now, because of that, because of the lack of access, the lack of normal preventative medicine happening, you will see a lot of rare diseases present that like in school you're taught like you'll never see this is a zebra. They are out in the rural sites presenting themselves. So it's definitely interesting. It keeps you on your toes because you never know what might come in out there. But very similar but also different. I think it's hard to say that one is better than the other. They're just very different. And I think as a PA, it's a little bit different than a doctor because the doctors feel like they sometimes lose skills being out at the rural sites because they aren't doing as much of the intubation and airway procedures. Whereas in the rural sites, the PAs are kind of gaining skills and vice versa in the urban. All right. And then I got some quotes from the PAs that I went to school with, just talking about like work-life balance. I feel like there's this notion that PAs have this like much better work-life balance and that they work a lot less than doctors. And I don't think that's necessarily true. So I picked some of these quotes. One of my friends said, "I knew what to expect because I shadowed several PAs before deciding. I had asked if they got into PA school or PA program and realized anything that they weren't expecting." So I think if you are deciding about going PA versus MD or other field, you really need to take the time to shadow those specialists and really understand what their day-to-day looks like. It'll make a big difference in the end. So my friend that works in surgery said, "I work as much as my supervising doc, but the work is different." She ends up taking a lot of the call at nighttime, answering a lot of the nurses' pages and handling the parents, probably more so than her supervising doc does, but she feels that they work the same hours. Whereas my other friend who works with a surgeon says she works more hours than our surgeon, but still has a really good life balance. I think a lot of surgical PAs work more than their surgeons. I think what will end up happening is the surgeons worked their butt off all the way through their 30s. And when they hit 40 or 50, they hire a PA to help do their night call and their weekend hours and some of the things that they would prefer not to be doing, which is great for the surgeon. And most of those PAs still seem very happy, but it's just something to be aware of that I don't think all PAs are like working less or necessarily getting like better hours. A lot of times you actually end up with worse hours than your supervising physician. One of my PAs that works in the ER with me said she thinks she works more than the doctors on the team. because, right, we're both working the same hours as the doctors, but we make less money. So a lot of PAs work more shifts overall to make up the difference. But she did say she thinks she's generally happier than most of the doctors, which I would agree with. I think I'm less burnt out and generally happier and satisfied in my job than most of the doctors I work with. And I'm not quite sure if that's just my disposition or the fact that I kind of knew exactly what I was getting into when I signed up for it. And then my one friend is working part-time, and she said it's been great for her family. And that's the nice thing about being a PA, is that you come out with less loans. So if you decide you want to work part-time or take time off, it's actually attainable. So we're going to end really early. I wanted to have plenty of time for questions. I know I kind of sped through that, so.
I'm muted. Sorry. Thank you. That was great. Thank you so much, Shelly. And yeah, we'll get started with the Q&A. We've got loads of time, which is great. Again, any attendees, if you have any questions, please post them in the Q&A section. And also make sure to upvote the ones that you would also want answered, because I'll go through and read out the most upvoted comment or the most upvoted questions, just so we get the questions that most people want to hear from. So I guess we'll go ahead and start right at this first one. What was your favorite rotation? Also, do PAs usually get their first job from the rotations like you did?
My favorite rotation was probably my orthopedic, excuse me, my orthopedic rotation. I rotated with an orthopedic doctor who did kind of like sports medicine, knees, shoulders, and elbows. And that was really cool. When I decided to be a PA, I actually shadowed a surgical PA, and I thought for sure I was going into surgery. And all the surgeons I rotated with were like, you need to go into the OR. I think at some point in my career, I probably will, because I love the OR. So that was probably, besides the emergency room, one of my favorite rotations. I do think a lot of PAs get job offers on rotations, especially if it's like a site that's looking to hire. I also had applied for some fellowships at the time on the East Coast because I thought I might move. They do offer like 1-year fellowships for like ICU PAs and ER PAs. Now there's debate whether or not those fellowships are like a total scam to get you to work for less money while they train you or worth the extra training. But my friend did like a cardiothoracic ICU fellowship. So she runs the cardiothoracic ICU at nighttime as the PA and first assists on like open heart surgery. So she did a 1-year fellowship for that after school, and then she got hired on as a PA. So that's another option. I think some people just kind of went the normal route, like applying for jobs, but I think it's very common to get job offers on rotations.
Awesome. Thank you. Another question in the chat was, is it common to take a gap year after you finish your prereqs before applying to PA school? Most schools recommend 4,000, 2 years of clinical experience.
I think it's more common because the average age of PAs starting school it's lowering, but it was like the upper 20s to 30s. So for a lot of people, it was a second career. They may have been a medic for a while, or some people are even like teachers or something totally non-medical and then decide to change career paths. And so they get that clinical experience just through life and kind of those gap years. So most of the people in my PA program had time off between undergrad. There was a few that went straight in. If I had known I wanted to go PA my junior year, I might not have needed the gap, but the application schedule is weird. You apply in, what is it now? July and August. You apply in like May, June, July for the following August start date. So you really have to time it appropriately, and you'd be applying the summer before your senior year of graduate or undergrad in order to not get a gap year. But I think it is really common for people to have a gap.
I see. Thank you. The next question is, what is the difference between a PA and a nurse practitioner? From what I have heard, a nurse practitioner can often diagnose patients and prescribe medication as well. They also have more lateral movement.
Yeah, so side by side in the ER, we have NPs and PAs. You honestly won't notice a difference. We have the exact same scope of practice. It's just a different route of getting there, right? So if you start as a nurse and then want to go to NP school, that makes sense. If you're not already a nurse, you would go the PA route probably. And there are some nurses that choose to go to the PA route. The PA route follows the medical model. So we're taught the same like method as medical school, the same like where you do differential diagnosis, and the same methodology of diagnosing someone is taught the same way in PA school. NP school is under the nursing model, so it's a very different way of learning. It's very self-directed. I've heard a lot of nurses say they felt like they didn't get a great education in NP school, especially with so many NP schools being online nowadays. And that's not to say there's not a ton of great NPs out there. But especially if you don't have a very strong fundamental knowledge of medicine, I think PA school is going to better prepare you coming out.
I see. Thank you. Another question that I wanted to ask, was working as a scribe beneficial to you? Do you feel like it benefited your knowledge / understanding of medicine, or was it just a way to get clinical hours?
I think at the time I applied because it was a way to get clinical hours, 100%. I was like, I don't have to get touch hours. This is great. I'm going to Scribe. But I can't say enough like how valuable it was. One, for my charting, you're trained to chart to the highest level of billing as a scribe. You know exactly what needs to be in the chart. And in PA school, everyone was like, how did you already know how to do this? Like, it was just a whole section of schooling that I just already knew what I was doing. And you really, if you are really using the opportunity as a scribe to absorb everything like a sponge, especially if you can get into a site where you want to be, potentially, I was a scribe in the ER. So I got to see so many cool things. At the time, I just thought it was interesting, but it actually helped me so much when I later got into my career and realized like, oh, I've seen this and I know how this runs.
Cool. Thank you. The next question, what is your experience like working with rural communities? Are there times where you wish you had more / better technology to work with?
Yeah. So luckily our ER has gotten a lot better. We used to not even have a CT scanner out at the rural site. So it was essentially like an urgent care. So that was frustrating. Luckily, because we're on the Gila River Reservation, it's actually interesting because it's a real like local model of socialized medicine. The tribe is paying for all of the healthcare and the hospital and the providers. So it's a completely different healthcare model that's happening out there. And because it's the tribe taking care of its own community, they invest a lot of money in the hospital. So whereas a lot of other places are understaffed and overworked right now, they overstaff that place and get us like the equipment we need, which is really, really great. I think the most frustrating thing about being in a rural site is like seeing a patient with a recurrent issue that it has like so many like socioeconomic like walls that are impeding their ability to get better that you can't like necessarily fix from the ER. A lot of times we end up using the ER as like a holding place until we can figure out a safe discharge plan, because people don't have electricity to run their oxygen tanks and things like that you just don't get in the urban sites.
I see. Let me see. Okay. Since PA school is shorter than medical school, would you say PA school also prepares students well for feeling comfortable while practicing?
Yeah, I think the first like year or two out of PA school is going to be similar to how a resident probably feels, an intern or a resident. You feel a little lost, but that's why you have a supervising doc or an attending over you. I think the biggest thing is you really have to make sure you take a job that is willing to train you. As a resident, obviously, you're going into residency. They're there to take care of you. But as a new grad PA, you could easily be dropped into a job where they just expect you to go. I was lucky enough, I had a really good supervising doc at the urgent care who worked with me on site for the first 6 months and was always available by phone call. So if I had questions or concerns, there was always someone to reach out to. So I think it's really important as a PA to make sure that you set yourself up for success by making sure you have a good team that's going to teach you and train you.
I see. Thank you. Another person asked, how does the cost of PA, so kind of going from there, how does the cost of PA school compare to the cost of medical school?
So obviously it's dependent on the program, but just time-based. So I went to Midwestern University. It's a private university. It's expensive, but it's expensive for the med school too. So people that came out of med school there had up to like $500,000 in loans. I had like under 200K coming out. So that's still a lot of loans. I didn't have any like familial support going into school. So I took the full loan amount I could to pay for rent, living expenses, and schooling. But that's half of the burden, you know? And I think there's a lot of loan repayment options. There's pay as you earn, there's other loan options where, yes, you want to make financially smart decisions, but it's also whether you not you go PA or MD, you're going to make enough money to pay off your loans eventually. Now, I will say, if you take $500,000 in loans as a doctor and then work in like pediatrics where you're making like 100K, that's going to be a struggle. So that's something to think about. You know, I'm lucky in emergency medicine. It's one of the highest paid specialties as a PA. So I make more than like a pediatrician would make.
I see. Kind of going off of that one. I just saw a question. Oh, how many hours of shadowing should students complete before applying to PA school?
I don't think there's necessarily like a set hour. I think you should probably look at like a few different specialties and potentially shadow. You definitely want to see like PA versus MD versus maybe something else. And spend at least a few full days with the person. I think most of our routines in emergency or in healthcare in general are repetitive. So as long as you've seen a few of those full days, you've seen some good days, you've seen some bad days, you're going to have a sense of what it looks like.
I see. And then like outside of scribing or shadowing, what do you think is the best way to get some clinical hours before applying to PA school?
I've seen people that did like tech work or like MA because that doesn't require too many extra credentials, because I think that's one of the big concerns. It's like, are you going to go get another certification in something just to get clinical hours? So if there's something at your school or the hospital that you can get involved with, or like in urgent care where you could work part-time as an MA, I think those are good options where you'll still get like really good experience, but also won't have to go through 1,000 hoops to get said experience.
And then also going off of that, Hannah asks, what are some great resume boosters for pre-PAs or pre-meds? And is there a real difference in what you should be trying to get into for pre-med versus pre-PA?
I don't think there's a huge difference. Like I didn't like curate my resume for going PA. I had all my pre-med recs going into PA school. That is something to think about if you do go PA. That's a good point. Is PA schools do not have a set list of recs like med school does. Every school has different class requirements, which is super annoying. So it's something to keep in mind before you go through that application process. If you're like early enough in your undergraduate career that you can really look ahead and plan out what this grid of overlapping prereqs was, I think that would be super helpful. I think the biggest thing that most schools want to see, especially PA schools, is they want to make sure you understand what a PA is, that you're going PA not be as like a second choice to being an MD, but because you want to be a PA. If they see that you're just like, oh, I could never get into med school, so I'm going to give this a try, good luck. You're probably not going to get accepted. But I think they want you to show that you really understand the field, you've had some good experience, you care about patients and medicine in general. So just try to find something that's health related that you're passionate about, because I think that's probably what's most important.
I see. And then I know you mentioned that the requirements will vary from school to school, but from what you've seen, does your undergrad major matter for PA school much? What about for medical school? That was another question.
I think especially now more and more. Now I'm not on any like boards of applications, obviously, so I can't speak too specifically, but especially PA, so many people are second career. that it really probably doesn't matter what your undergraduate is as long as you have those prereqs. I think more and more we hear about med schools wanting people that are like non-medical focused, doing like a liberal arts or something, but getting all those prereqs. So I think it's up to you. My parents' advice going in why I did engineering was to get a degree where if you don't get into med school or you don't get into PA school or you change your mind, you're going to have a job coming out. Because if you pick a weird major to decide you don't want to go into medicine, now you're really screwed. You have to do something.
I see. Thank you. Let's see. So I think this is more so talking about the career instead of the schooling, but do you like working more in a fast-paced environment or a slow-paced environment when it comes to your job?
For me, probably fast-paced. I feel like the ER is very like, it's caused me to like develop ADHD. You're always going. You're always a little distracted, but it definitely makes the shifts go by faster. I work shift work, so I'm working 10 to 12-hour days. If you're sitting in an ER for 12 hours with no patients, that's a really long 12 hours. So you want like steady but manageable, which I think the nice thing about my job is there's enough providers where you'll never feel like someone is going to die because you're not moving fast enough. I think a lot of jobs nowadays push you to move. So there's probably like a healthy balance in there, right? You want to make sure you can go eat some lunch in the back and take a second to breathe.
Right. That makes sense. What PA settings and specialties would you personally recommend to shadow in?
So there's so much like different scope. So I think it really is kind of dependent on your goals. So, you can do primary care, you could do pediatrics. I think shadowing in a surgical subspecialty would be really cool if you can get into shadow one. Dermatology, a ton of PAs are going into dermatology. So if that's something you're interested in, we also have a lot of like people from school who went into like telehealth, like psych stuff. So if that's something you're interested in, PAs are definitely involved in psych. For me, I was not interested in that at all. But really, it's kind of the same thing as MD, right? If you can think of the specialty, there's probably a PA in it. So it's just a matter of finding one that's willing to have you shadow, but they definitely exist.
I see. And kind of following up on that, would it be useful for someone who's looking into psychology or psychiatry to become a scribe? And is a PA able to switch to psychology or non-surgical areas?
Yeah, so a ton of PAs work outpatient and don't do any procedures. You can do like telehealth and work from home. I have a lot of friends who are moms now and do like primary care telehealth appointments. And they work regular hours. They do, your routine blood work, your routine stuff. Now, as far as psychology stuff goes, you're going to end up doing like psychiatry. So you'll be the person like prescribing, but you're not a therapist. So you won't be doing cognitive behavioral therapy. And you'll see that on your rotations too. Like we do a psych rotation in PA school. We did inpatient psych. It was a PA running the department. You're prescribing the psych meds, but you're not necessarily doing like the therapy, which I think a lot of people don't realize. If you want to go into psychology and do therapy and like all of that stuff, that's a separate route. Both MD and PA is going to be a very medical model of behavioral health. You're going to end up managing the medications and things like that.
I see. And then we have Sarah wants to ask a question live. So she has her hand up. So I'm just going to allow her to talk. Okay.
Hi. I was wondering if you could talk about how you have to work with other specialties in the emergency department, because I know you have to like sometimes specialize into OBGYN or ortho or arrange transfers. So I was wondering if you could explain how that works as a PA.
Like me doing orthopedic procedures or me calling ortho down to the ER?
Just like your relationship with ortho and how that works out. Because I feel like as an MD, it would be easier and less terrifying to just call the ortho specialist. Whereas the PA, you might struggle with that a little bit more.
Yeah, sometimes, especially like depending on who you're calling, I feel like from the rural site, we end up having to call these big hospitals. They have no idea who you are or why you're calling. And they occasionally will be like, who is this human, and try to like kind of stomp on you. So you have to be able to stand your ground and like advocate for the patient. I think at like university, it kind of works out nicely because you're always calling the residents and the interns. So especially right now, they're super nervous. So they are less likely to be kind of rude and condescending to be as a PA versus an attending. And like the other day I had 3 or 4 patients that all had specialists come down to the department, and they were handling all of my patients. And I was like, this is great. And like I had a complex lack that the facial group came down and fixed. And those residents were super, super nice. But occasionally you get an attending who's just not nice. They're burnt out. They've had a bad day. You know, we have some hand specialists that take call for the entire state of Arizona. They don't want to hear from you, and they will let you know that. But you just have to kind of stand your ground and advocate for yourself. I think once or twice I've had my like male attending counterpart take over the phone because I'm just unwilling to scream at another person. But usually it's pretty, you know, cooperative. Sometimes you're actually talking to the other PA, which is nice, but you just have to learn to stand your ground. Like you have to feel confident. You know what you're doing in the ER. You're not crazy. You're calling them for a reason. So just make sure you advocate for what that reason is.
Cool. Thank you. I think we've got time for a few more questions. Let's see. Which specialties have more regular working hours? So you have that more work-life balance, I'm guessing.
Yeah. So I will say in the ER, I work weird hours, but I only work 3 or 4 days a week. So it's pretty cool. I get like weeks where I get 4 days off. I only work 15 days a month. Full-time is 10 days a month. I just work like a crazy person. So most ERPAs full-time would be 10 shifts a month. You would have 20 days off to yourself, which is really cool. It's one of the reasons I like it. But I mean, anything outpatient is going to have pretty regular hours. So, you know, your outpatient internal med, your GI, urology, the urology PAs sometimes get crazy hours. But one of the cool things is you can really design it yourself. So when I rotated with the surgical PA, she only did the OR. She did OR and inpatient only. She did surgery 8 a.m. to 3 p.m., was done, rotated on the weekends, and her outpatient counterpart PA was only in clinic. She never went into the OR. She saw patients for pre-op and post-op and only worked Monday through Friday. And so they kind of split the roles that a normal surgeon would have into what they wanted, which I think is one of the really cool things about being a PA.
That actually sounds really cool. Oh my gosh.
Yeah.
Thanks for that. Have you seen any cases of monkeypox in the ER?
Not yet. I swabbed a patient, but they were negative. It was funny because she was, of course, in like a group setting with a rash. And I went to go get my attending because I was like, will you look at this rash? And everyone hates rashes in the emergency department. No one ever knows what they are. He's like, I'm going to tell you it's a rash. And I was like, I know, but just come look. And he was like, that looks like monkeypox. I was like, I know. So we had to call all the people, infectious disease. There was thousands of phone calls just to figure out how to swab the patient because there hasn't been many cases in Arizona. Like East Coast, this is all set up. People know what they're doing. We have no idea what we're doing in Arizona. So we swabbed her, but she ended up being negative. But there have been a handful of cases that have come through my ER and other providers saw.
I see. Thank you. I mean, thank God they didn't have my monkeypox.
Yeah.
Let's see. Is there a significant salary difference between a primary care MD versus primary care PA? As an example, in other specialties, is it common for both providers to be working at the same time and for the same hours?
Yeah, so I can't speak directly to like direct salary, but in the ER I can speak, and I'll just tell people numbers because I don't care. It's probably not polite, but that's fine. So in the rural site, the doctors make close to $200 an hour, which comes out to, I don't know, let's see. If they worked just full-time hours, which is 120 hours a month, they would be pulling in $24,000 a month, which would be like 300 grand a year. Most doctors work more than full time, so a lot of them are pulling in anywhere between 300,000 and 500,000. As a PA there, I make $90 an hour, but I work like 170 hours a month. And so like last year I pulled in like close to 200, but that's rare. I think most PAs are making six figures, 100 to 100 plus. I think outpatient, you're looking closer to like six figures, just flat, but it really just depends if you're willing to work overtime, what kind of bonus structure you get. A lot of people will get, you know, one of the benefits of my job is I don't pay anything for my healthcare. There's no monthly cost at all for my healthcare. So those kind of benefits you have to weigh into. I make less at my urban job, but I get paid RVU, which is based on like patients per hour and my productivity. I get like extra money. So these are like the little things where you negotiate. But I think in general, if you put MD salaries versus PA, it's going to be slightly less than half. But you also have half the loans and are working for longer. So that is something to keep in mind. Some days I'm seeing more patients than the doctors for the same amount of hours, and they're sitting there on their phone. And I'm like, this is great. So you just have to deal with it. You know, that's what you chose.
All right, well, thank you so much, Shelly Garland. I think it is 5:56, so we are at the very end. But thank you everyone for attending this wonderful session with PA Garland. And as I mentioned at the beginning, this was our last speaker session for today. So this concludes all of our speaker sessions for the first day of the National Pre-Health Conference. I'd say we ended off on a very, very good note. So please make your way to the closing remarks session. So you'll leave this webinar and you'll join another session, and it'll be called closing remarks. And so you can leave this meeting and join the session through the Zoom events lobby.
Thanks, guys. And you
Thank
can
you
always
guys
email
again
me
so
or
much.
whatever if you have questions.
Oh, do you want to send the email? I can also send the
Sure.
email.
Want me to put it like in the comment box or something?
Yeah, in the chat box.
Okay, let's see. It's the iPad life.
Yeah. All right.
Perfect.
Yep.
Thank you.
Thank you guys so much, and see you in the closing remarks section.
Good luck with the rest of conference.
Thank you. Thank you. All righty. I will end this.